So our next session is going to be about improving patient outcomes through optimizing the use of medicines. And this is the first presentation of a 2013 survey on medicines management and optimization in the new NHS, with a discussion of the key findings. We have two speakers, and I'd like to introduce Ivor Eisenstadt, initially the Managing Director of MGP. Ivor.
Thank you very much indeed. Yes, welcome to this session on improving patient outcomes through optimising the use of medicines. Can you all hear me? Because I know there's a bit of a sort of noise around us. At the back, can you hear all right? Yep, okay, good. Yes, I'm Ivor Eisenstadt. I'm Publisher Managing Director at MGP. We publish a range of best practice publications, guidelines, e-guidelines, and I'll be introducing Bill to you shortly. And what I want to look at really is what we're going to be looking at is improving patient outcomes through optimising the use of medicines. And hopefully by now you're aware that last month there was published by the Royal Pharmaceutical Society this publication, Medicines Optimisation, helping patients to make the most of medicines. Who's seen this paper? Okay, so it's widely out there and you've seen it. Excellent. In the introduction it states that medicines use today is too often suboptimal, and we need a step change in the way that all healthcare professionals support patients to get the best possible outcomes from the medicines. And it went on to say that medicines optimisation represents that step change. Step change. So it's not just simply a sort of an evolution, in a sense, for medicines management. This is a step change that the NHS is looking for. It goes on to say that medicines optimisation is about ensuring that the right patients get the right choice of medicine at the right time by focusing on patients and their experiences. And that goal is to help patients to improve their outcomes, take their medicines correctly, avoid taking unnecessary medicines, reduce wastage, improve safety. And ultimately, medicines optimisation can help encourage patients to take ownership of their treatment. It really is all about patients taking ownership of their treatment. And we at MGP decided to carry out a survey ahead of today's meeting, looking at medicines optimisation with the aims of assessing the current understanding in the NHS of medicines optimisation, but also to inform the discussion that will take place after these presentations. It was an online survey conducted in May, and we took the first 500 responses. About 45% of the respondents were GPs, so nearly half were GPs. The next largest group were pharmacists, followed by nurses and hospital doctors. So we asked a range of questions. And I'm just really putting out some of the key findings, and you'll be able to go online and look at the full research after this presentation. But currently, how many individuals are there in your medicines management optimisation team? And you can see that over half we're talking about 1 to 5. We're talking about relatively small teams, 25% 6 to 10, and only 4% were really 11 or above. So medicines management optimisation teams, relatively small. And in terms of how they're looking to see them grow, well, what they're saying over the past year, how has the number of personnel within your team grown? We're talking really about staying the same 61% and then an equal number having either increased or decreased. So it's pretty much stayed the same. And that might seem a surprise to some, bearing in mind the major uphaul that's been going on over the past year, couple of years. And over the next year, how do you expect the number of personnel in your teams to change? Well, the vast majority stay the same. Although there is a slightly larger percentage saying that their team is actually going to increase over those that are saying it's going to decrease. So it's medicines management, medicines optimisation personnel are not going to be going away. If anything, they're going to be more of them. What are their priorities going to be? The number one priority, I guess no real surprise to everybody, the number one priority was containing costs, followed by managing the prescribing budget, improving quality, implementing national guidance, and reducing events rates. Developing and updating formularies was also high on the list. What was interesting was that, surprisingly in some ways, GPs had in terms of where they rated the various priorities, actually GPs saw costs, more GPs saw costs as the highest priority as a percentage of GPs than pharmacists did. Pharmacists were actually equally split as to the highest priority between cost and quality. Which disease areas? The long-term conditions clearly out front, cardiovascular, respiratory, but infection also very high on the agenda. And what sort of support might they be looking for over the next 12 months? A lot of it's practical help, practical support. They're looking for good practice examples, guidance, training, information, help with data analysis. There's going to be a wide range, there's a variety of needs in terms of support, and obviously it will depend upon how well advanced the various medicines management teams are as to what they're going to be needing, but they do need help and they do need support. We asked about formulary committees and which formulary committees are you currently members of. So this is from the e-guidelines audience. 46% were members of practice formularies, 23% CCG formularies, and of course CCGs are rapidly developing formularies. Trust formularies 15% and area formularies 16%. When looking at how they might see it in 12 months' time, in terms of where's the decision-making authority likely to be in the locality, 53% said CCG formularies. So bearing in mind, going back, we're looking here at CCG formularies being 23% in terms of their being involved in them. 53% were saying the CCGs is where the power is going to be. 20% said area formulary and 16% trust formulary. And of course, those who were respondents from the trusts were the ones that basically said the power is going to be in the trust. So I guess there's clearly going to be some issues around whether the CCG or the trust or indeed the area take the upper hand when it comes to decisions around formularies. And the focus, this is the really interesting one, which of the following do you feel that your local formulary committee is currently more focused on? Medicines management or optimisation? At the moment, it's medicines management. Look forward a year, and you can see the shift is clearly towards medicines optimisation. But what do they mean by medicines optimisation? So we asked them, how would you describe the difference between medicines management and medicines optimisation? 75% of those that responded to this question gave a written answer in terms of what they understood, but 18% they didn't know, and 7% said, actually, they're the same thing, there is no difference. The sort of quotes we had were unclear, not sure, don't know, it's not been explained to us, they're the same, no difference, I use them both to mean the same thing, and, well, it's not my job to make the distinction. That was from a GP. We then, looking at the various comments, were then able to tease out what the key focus were from these comments. And what's interesting is that firstly, if you take those comments that focused on being patient-focused, medicines optimisation had 41 comments saying that medicines optimisation was patient-focused. Medicines management had 2. And the sorts of comments were medicines management is focused entirely on medicines, optimisation is patient-focused. So the message is clearly getting through on this front. Medicines management is getting best cost-effectiveness where optimisation does this, plus includes getting best clinical management for the patient. Medicines optimisation is more patient-focused and is more patient-centred and respects the patient needs. So the message in terms of medicines optimisation and the patient came through very clearly from this survey. What about costs? Well, medicines management, we had significantly more comments saying that medicines management was focused on cost. But having said that, there was still quite a large number saying that medicines optimisation is very much focused on cost. Comments such as medicines management is about increased efficiency and cost cutting. Medicines optimisation is about optimal choices. Traditional medicines management has been about cost-effective prescribing. Medicines optimisation is a more patient-focused medicines management system. Optimisation is on the appraisal of medicines. Management is control of the budgets. And the focused, money or patients, which I think is an interesting way of sort of categorising in a sort of black and white way. What about quality comments? Medicines optimisation had far more comments than medicines management, stating that that it was quality focused. Medicines optimisation is a more patient-centred approach with a drive to attain quality outcomes by a balance of evidence-based, safety and patient choice. They're shades of the same thing, but management focuses more on cost, optimisation more on quality. So again, the message the message, the shifting away from looking at purely the financial side, focusing more on the patient, more on the quality, is coming through. Although there was one comment, management more focused on clinical quality and safety and optimisation more focused on cost, that bucked the trend and showed that clearly there is still, in some people, really a lack of clarity of the distinction. About processes, medicines management seem to be more process and systems focused. Medicines optimisation, more patient. Medicines management, more system focused. Medicines management, more about ensuring efficient systems. Medicines management's more overviewing the prescribing process. And medicines optimisation, again, belying the trend, is a whole system approach to achieve the maximum health gain and least harm, which I think actually is a good summary. So it clearly is, there are processes involved, but very few people focused on that as an area for medicines optimisation. And in terms of outcomes, medicines optimisation is seen to be more focused on outcomes. Medicines optimisation is a more patient-centred approach with a drive to attain quality outcomes by a balance of evidence-based, safety and patient choice. Optimisation is about getting the best outcome for patients, but again, there are those that focus in medicines management is the entire picture to improve patient safety and improve outcomes. So whilst the message is coming across that, and this was, I think, a nice summary quote really, medicines optimisation is an approach to the quality use of medicines, focused on outcomes rather than process, patients rather than systems, and is led rather than delivered by pharmacists. And that's from a GP. And another nice one, medicines optimisation is about, again from a GP, medicines optimisation is about the patient, following guidelines, value for money, but thinking about patient outcome, so the whole medicines pathway. So I think that's good news. I think there is out there from the response we've had is there is an understanding. It's not across the board, but there is a strong understanding. There were some comments were slightly more cynical. One is a nicer term, less coercive sounding. But then just to finish the quotes, there was one which basically stated optimisation is the future, and I think that is very much the intention of the NHS and the intention going forward. So that's the very top line on the survey. There's a sheet which allows you, which will have the URL with the survey on, if you want to go to the full results. But I'm going to hand over now to Bill Sandhu. He's Interim Associate Director, Medicines Management Lead at the North East London Commissioning Support Unit, and previously was Associate Director, Head of Medicines Management at NHS South West Essex. So over to you, Bill.
Thank you, Ivor. It's impossible to cover a lot of detail in the little time we've got, so what I'm going to try and do is contextualise things a little bit for you. So in order to do that, I kind of need to explain a bit about my background, the organisation I currently work for, and talk a little bit about what medicines optimisation means to me, and then perhaps in the context of that have a discussion about some of the results. Now, the organisation I work for, North East London Commissioning Support Unit, as you can see, has a sizable geography. And that means that there's a significant opportunity for my colleagues and I to be exposed to opportunities to improve the use of medicines. And that's further supported by the organisational ethos about supporting commissioners to make tangible and positive differences to their local populations. And a key driver for me and part of my organisation is to help deliver beneficial patient outcomes. Now, I think that medicines optimisation is really something we've all aspired to. And what it's really about is thinking through the whole process. So rather than thinking about here's a pill and potion, that's the end of the story, it's about how do you even select the therapy. And I say therapy deliberately because actually if you have a mental health condition, one of the talking therapies may give you a better outcome than a medicine that we might be able to prescribe you without the side effects. If you suffer with a skin condition, access to things like Puva for psoriasis is probably a better therapy option than actually using a medicine. To me, that's part of optimising outcomes for patients from the use of medicines. So it's about which therapy do you select. It's about how you get it available in your particular locality, and then how it gets to the patient. There is the issue of prescription, because we do know that prescription errors do contribute to harm to patients. And actually doing that safely requires systems and processes. And the most important element probably is the administration and review. And I really believe that can't be done properly unless there's a shared decision-making with the patient. The management plan is something the patient is part of and signed up to, and understands that what they're not going to get is a potion to fix their problem, but a solution that helps them change the way they perhaps live, the way they conduct their lives, what they eat and drink, and how they can contribute to a beneficial outcome for themselves, with a medicine as part of that solution and not the answer. So it's really focusing on the patient and very much tailoring the resources you have available to get the benefit for the patient and minimise the side effects. So if that's the case, then what does this mean? Now, for commissioners, for CCGs, this creates quite an interesting dynamic, I think, because as clinicians, we all want to focus on the patient in front of us and what's best for that patient. But actually, we're relying on lots of other people to do their bit to make sure that the patient gets the benefit. The stats out there say that between 50 to 70% of patients don't take their medicines the way the healthcare professional that prescribed it to them intended. Now, that's a major issue, because actually we're not giving that patient a chance to get the benefit. And tackling that is quite difficult. What strikes me as particularly challenging for CCGs is that you've got a fixed financial envelope that's time-bound, which you have to deliver within, and the outcomes might take years to materialise. So quite how we square that circle, I haven't figured out yet, and if anyone's got an answer, please tell me. But I think the move towards involving patients in that and thinking about the whole system is actually the right direction of travel. The big issue, I think, for all of us is going to be having the capacity and capability to deliver that. And I've noted that in the responses that people were of the view that medicines optimisation is less about systems than medicines management. And I would put to you, actually, it's probably the other way around. Because if you're going to optimise a patient's care with a multiplicity of providers and lots of involvement and engage the patient, then you may actually need more systems rather than less. But the systems need to work properly and be integrated. Now, interestingly in the survey, I think that the majority of responders were physicians. I think that had the survey been about medicines management, that might have been different. But I also think, and I'm very encouraged by the fact that we've had such a large response from the people that are actually going to be delivering care to these patients. It's a level of engagement that actually is very promising in terms of moving things forward. A slight concern of mine is that in terms of commissioners for medicines, they were one of the smallest groups that responded to this particular survey. Now, does that mean that their mindset hasn't caught up with where we ought to be? Are they just disengaged? I don't know the answer to that, but I have concerns if commissioners with experience around medicines are not able to bring a useful contribution to the table. It was also notable that a large number of responders to the survey were actually service providers. Now, that could be encouraging. It could also be indicative of a flawed mindset. So, as a provider, actually, I'm paid on a tariff, and the tariff will support my infrastructure, provided I get enough volume of business through quickly enough. And if I see a drug as a means to getting people out from my service so I can fill that space with another patient, that actually becomes a problem in optimising care and outcomes for the patient. And it's something that needs to be carefully thought through, I think. The other thing that was quite interesting, I think, that people recognised is cost containment and budgetary control issue. But I would put to you that in terms of medicines optimisation, budgetary control is thinking a little bit more outside the box with regard to budgets. Because if you have a service that's provided differently, then actually you might need to wire money over from somewhere else into the medicines management budget to be able to help your patients get better outcomes. And it might also go the other way, but it requires that sort of collaborative approach and a thoughtful implementation process. And one of the issues that was quite interesting is that responders are generally small. When you think about the fact that the average CCG has 40 practices, and actually the bulk of respondents, around 70%, were from 25 or less practices, that's quite interesting. I think that creates some tension sometimes when you're trying to manage something at an individual patient level, at a group level, and a population level. And for that, actually, project management skills might become very, very important. And that's something perhaps to dwell on a little bit. The decision-making sitting with CCGs, I think, is intuitively, it feels right. But there does seem to be, I think in my view, a big need for significant collaboration, because actually 90% of healthcare is delivered in primary care, 75% of interactions with the healthcare professional result in a prescription. The other 10% of your business that goes through secondary and tertiary providers actually probably spend 60% of the money available to you. And without collaboration and getting those people on board, actually we could be facing more difficulty going forward. I'm an optimist. I think this is a real opportunity, but one must be mindful of that, I think. Now, it was interesting that most people were not sure what medicines optimisation meant. And I've tried to give you my sort of personal view of medicines optimisation. And the more I think about it, the more I think what would have been a more useful terminology perhaps is medicines as a means to optimising patient outcomes, because that's what it's about. The medicine is not the end product. The end product is the outcome. The medicines is just an enabler. And I would just go as far as to say it shouldn't be medicines, it should be therapy. Because actually it may not be a medicine that's appropriate for that patient. And sometimes we over-medicalise things. But again, that's just my view from the sort of work that I've undertaken in the past. I am really, really encouraged by the current move to put commissioners that are clinicians in the driving seat. That does create some significant challenges for us managers, but I think it does keep a sense of realism and actually contact with real people and their needs. The fact that you are, as healthcare professionals, dealing often with very complex situations and understand the social environment as well as the physical environment of the patient and the mental health needs actually puts member practices that are part of CCGs in a unique position to really change the system. And the local intelligence and knowledge is key, because actually no system, no structure implements anything. It is people. And if people have buy-in and understand what they're doing and work to a common agenda, that will deliver. I do think there are some challenges, because we are going to have to change our sort of very didactic, methodical approach to treating conditions as a medical problem. And that requires a sea change on everyone's thinking. And I think there is a lot of different cultures. You know, providers have an outcome in mind from their perspective. Primary care providers have a different outcome in mind from their perspective. But actually, this should be about the patient and what outcome we should be trying to get for them and what outcome they buy into. So without further ado, and those last few thoughts, I'm going to wrap up here and we'll take questions from people if that's okay. Thank you.
Okay, well, thank you both very much. And now, can we have any questions, please? While people are thinking, can I ask you both, what do you think patients consider medicines optimisation is?
I think they're probably as confused as we are, to be honest. I think, particularly with the media nowadays and the sort of move to a quick fix solution for everything and a soundbite, that everybody wants just the pill or potion to fix their problem. And that's an issue because that's not optimising the outcome from medicines.
What would you say?
I'm a patient. What do I want? I want to be listened to. I want time from my GP or my clinician. I want the relevant information, and when I have problems, I want to be able to contact my clinician to find out how I can adapt the medicine and what the issues around that might be. So, in other words, I guess I want time and I want dialogue.
Right, there's a question down here.
Jonathan Buisson from Boots. Where does pharmacy fit into all of this?
Well, I think when I say medicines optimisation and clinicians, I include pharmacy within that family. And my slight concern is I think the opportunity that pharmacists have to help patients through this journey has not been capitalised on. And I think the current NHS changes could lead to that either getting much better or getting much worse. And I wait to see what happens next. Patients do see pharmacists as a resource, and having worked in the community pharmacy sector, the number of times that patients would come to me with issues and I would know that they need to have a particular service or see a particular person, but I was not unable to do that as a pharmacist, it is too much to count. And I do think that's an element around how do we optimise the care of those patients. Ivor has said, as a patient, what you want is time, you want some support, you want information, and you want to be able to, in a timely fashion, get access to all of those things. And actually, much closer collaboration between primary care, GP practices and community pharmacies would certainly go a long way to helping that and would address the capacity issues. I haven't got the answer as to how you do it, but I think in this new medicines optimisation field, that's a real opportunity, and if we don't grab it with both hands, then shame on us, I think.
Yeah, I think that one of the key points that's coming through from medicines optimisation is the shift away from, in effect, medicines management really was seen to be owned by pharmacy or pharmacists, whereas clearly medicines optimisation is perceived as multidisciplinary, and it's really all about collaboration. It's bringing about everyone who has something to give to the agenda in support of the patient. And as far as pharmacy is concerned, again, coming back to being a patient, what I want is to be able to talk to somebody in the pharmacy about my drug, about my issues. And if you look at what the Royal Pharmaceutical Society report, it has 4 main elements. Aiming to understand the patient's experience is the first one. I want my pharmacy to understand my experience and be able to respond accordingly. Second one's evidence-based choice of medicines, again, to support that agenda. Thirdly, to ensure medicines use is as safe as possible. And again, that's all about dialogue. It's all about asking the right questions. And I guess from pharmacists' perspective, it means that you need to have the pharmacists, the assistants trained and with the confidence as well as the knowledge to have the dialogue with the patient.
Well, thank you very much indeed, both of you. I think that concludes this session, so thank you for a good session.